Hello, my name is Dr. Yakov Lawrence, a radiation oncologist from the Sheba Medical Center, and today we're going to talk about rectal cancer. This is an overview of the lecture. We're going to talk a little bit about the anatomy, the epidemiology, some of the causes of the cancer, symptoms, diagnosing and staging, the different treatment modalities involved, understand how these different treatment modalities come together, and then discuss some ongoing research issues. So the rectum is the final part of the gastrointestinal tract just before the anal canal. It's important to understand the difference between the rectum and the anal canal, especially from an oncological point of view, because they're quite different diseases. Anal cancer, which we're not going to talk about today, is a squamous cell carcinoma and treated with a combination of chemotherapy and radiation, typically without surgery, whereas rectal cancer is treated typically, at least in the locally advanced form, with trimodality therapy, both chemotherapy and radiation and resection. The rectum itself is about 12 to 15 centimeters in length and joins up with the sigmoid colon. Incidence of colorectal cancer varies very significantly across the globe, being highest in Western Europe and North America. Looking at how incidence has changed over time, we see overall incidence appears to be dropping in the United States. However, it is rising in parts of Asia, for instance, in Korea. However, please note that in these two graphs, the y-axis is very different, so absolute levels still remain much lower in Korea than in North America. An important issue over the last year or two has it's been noticed that the incidence of colorectal cancer is rising in those under the age of 50. You can see here on the left-hand side, this is the United States, and over 50s it appears to be dropping, but those under the age of 50 it appears to be increasing. This is both rectal cancer and colorectal cancer, and a very similar story in Europe for the colon and rectal cancer in those under the age of 40 in these graphs. Exactly why this is happening is unclear, but is thought to be related to lifestyle issues. So, regarding lifestyle and the food we eat, over the last couple of years, an emphasis has been put on the dangers of processed meat. In the WHO classification of carcinogens, they put processed meats such as salami, bacon, and sausages as in their group number 1. That is, chemicals which are definitely considered to be carcinogenic. So now salami is in the same group as arsenic, benzene, alcohol, asbestos, coal tar, diesel exhaust, wood dust, and of course tobacco. So really best avoided. Red meat, by the way, is also high up. However, that is put in group 2A as a probable cause of cancer. In terms of symptoms of rectal cancer, so patients often complain of some kind of change in their bowel habit. The classical thing is tenesmus. That's the feeling where patients go to the bathroom and they pass stool, but they feel that there's still more stool that they weren't able to get out, and often as a result they go many times to the bathroom and complain of multiple small bowel movements per day. They may also complain of alternating diarrhea, constipation, although be aware that patients use these words quite lucidly, so you have to ask what they mean by constipation or diarrhea. They may also complain of urgency, needing to run to the bathroom, and also incontinence. They often have some degree of rectal bleeding, and they may sometimes complain that their stools are quite thin. Many patients, by the way, have no symptoms, and it may just be picked up on screening. In terms of diagnosis, it's still very important to perform a digital rectal examination. and if that was performed more often, probably many of these patients would be diagnosed earlier. The majority of patients today are picked up on colonoscopy, as you can see in this diagram. However, be aware that colonoscopy does have a tendency to miss cancers in the lower rectum, and so therefore, as far as I'm aware, gastroenterologists will always perform a DRE just prior to the colonoscopy to pick up those cancers they may be missing. And then you have proctoscopy or rigid rectoscope, which tends to be performed by colorectal surgeons, and that's a very good way at both looking and also biopsying the rectum and the anus for that matter. Also during colonoscopies, of course, biopsies can be taken. So once a diagnosis is made of rectal cancer, it's very important to understand the stage of the disease. And when we do that, we talk both of local staging, what's the situation within the pelvis, and distant staging, what's the situation outside of the pelvis. Distant staging today is done by CT scan. If things are unclear, it's often useful to do a PET scan as well. In terms of local staging, classically we used to say that you can do either an MRI scan or a special type of ultrasound, what's called an endorectal ultrasound or transrectal ultrasound. At least in Israel we call it a TRUS, T-R-U-S. Be aware a disadvantage of TRUS is it's very user dependent, and afterwards you don't really have kind of pictures to look at, whereas with an MRI scan you may or may not agree with the radiologist's report, but at least you have a disk of MRI images that you can bring to your local expert. So the questions we ask when we're doing the staging, if we're looking at local staging, looking at the MRI or TRUS report, we really want to know the T stage, the N stage. We want to know about the CRM, the circumferential resection margin. Does, based on radiological criteria, do we think the surgeon will be able to take that tumor out with a clean margin? And also, as a radiation oncologist, it's important for me to know, are there lymph nodes which are outside of the mesorectum? That's important because I know those lymph nodes will probably not be taken out at surgery, and I need to give an extra dose of radiation to them. In terms of distant metastases, obviously we want to know if there are or there aren't metastases, and if there are metastases, are they resectable or ablatable? And I'll just mention here that in the world of rectal cancer, as in colon cancer, we're very aggressive when it comes to metastases. We really want, if possible, to have a complete resection or ablation of those metastases, which does improve survival and may also bring a certain percentage of patients to cure despite metastatic disease. Be aware that our ability to accurately stage patients prior to surgery is not great. We're fairly inaccurate. If we look at this paper that was published from Sloan Kettering, the leading cancer center in the world, you can see that they took patients, they thought they were all node negative. They then gave them chemo radiation, and then at the time of surgery, 22% were found to have positive lymph nodes. Now, we know that chemo radiation itself sterilizes a number of lymph nodes, so that means that probably in 35 to 40% of the cases, they thought cases were N0 when actually they were lymph node positive. So that the science of neoadjuvant treatment is imperfect. At my institution at the Sheba Medical Center in Tel Aviv, how do we stage? So this is a table I reproduced from Gunderson's textbook, which incidentally is an outstanding textbook, and I really recommend people interested in oncology, even if not radiation oncology, any type of oncology is an outstanding textbook and worth reading. History, physical examination. I'll mention I perform a digital rectal examination everybody I see for rectal cancer, assuming they allow me to. I don't rely on anyone. I feel very important to feel the cancer myself. Likewise, we work as a close team, and we send everybody to a proctologist before we start any neoadjuvant treatment. Colonoscopy is important. It can't always be performed because of obstructing tumors, but if it can be performed, it's important because that lets us know there's a synchronous additional cancer which is sometimes seen, and that will very much affect the surgery that has to be delivered. As I mentioned earlier, we tend to prefer, you have to perform TRUS or MRI, and we tend to prefer MRI these days. Important to mention, we don't believe all the MRI reports that we receive, and almost every MRI we bring for discussion at our tumor boards. And also each of us, each in his own specialty, has learnt some expertise in reading these MRIs. In terms of distance staging, a good CT scan with intravenous contrast is sufficient. If there are unclear findings, especially in the liver, either a PET scan or MRI of the liver can be very useful. In terms of risk factors for the disease, so a family history, patients with long-standing inflammatory bowel disease, obesity, red meat consumption. Just to mention, the difference in the rectum and the colon. Why is it that we need to radiate rectal cancers but not colon cancers? So to put it simplistically, the rectum is in the pelvis. It's a very confined space, as you can see on this diagram, and it's difficult for the surgeons to take out the tumors with a very large margin. Margins tend to be quite tight, and the radiation helps bring these patients to cure. It's also to do with the anatomy and the rich lymphatic drainage of the rectal cancer. One of the things that characterizes rectal cancer, as well as some other tumors in the body, is you really need multidisciplinary care, which also is a great word to use in your medical examinations. Lots of people need to be involved, not just different medical specialties, as we'll see in the next slide, but also ancillary staff, dietitians, stoma nurses, people to help, patient navigators to help patients navigate between the different medical specialties who are taking care of them. And we have, of course, the tumor board. The tumor board, this is a picture I found on the internet, but it looks very similar to what we do at Sheba. You have round the table the different medical specialties involved: the chemotherapy doctors, the radiation doctors, the surgeons, the pathologists, the radiologists, all looking at each and every case, and each person providing their own input. Really an essential part of modern medical care. So getting on to the treatment, I want to talk separately about the surgery, the radiation, and a touch about the chemotherapy. So historically, rectal cancer surgery was very difficult. There was one paper summarizing the situation up to 1900, and they really found that many patients died and the recurrence rate was incredibly high. The first person who really worked out how to do rectal cancer surgery was a fellow called Ernest Miles from London. And by the way, you're going to see that almost the entire history of rectal cancer surgery occurs in London. In 1908, he described his operation, and what he appreciated was you didn't only have to take out the tumor, you also had to take out the draining lymph nodes, especially those above the tumor. And based on that, he's able to very much reduce the incidence of recurrence. His procedure is classically called Miles procedure. Today we call it abdominal perineal resection. It involved an unblock resection of everything. So after this, you don't have a rectum or anus anymore, and patients have a permanent stoma, abdominal perineal resection. And here you can see this in graphical term. This is what's cut out, and you end up with the stoma here, and this is what's sent for pathology. Now, the problem with an APR is that you have a permanent stoma and you don't have a functional rectum. So efforts were made to try and preserve the lower sphincter, the anus, and the person generally assigned this, who succeeded in this, is Sir Alan Parkes, also from London, in the early 80s, and he described what's called the low anterior resection. These are important terms we still use today. The low anterior resection, where the tumor is removed, and then you need to anastomose the sigmoid colon to the anus, and here you can see it being done, in this case being hand stitched. Not every case can you do a lower anterior section on. You do need enough tissue here to do that sewing. So tumors which are very low and invade the anal canal, even today we need to do an abdominal perineal resection. Just to mention here, credit where credit is due. Very important in colorectal surgery, in fact all surgery today, is the use of surgical staples, which help surgeons do very low anastomoses, and actually this was a technology developed in Russia. So if we're looking at a kind of table of local recurrences, we see in the 19th century it was almost 100% recurrence after these operations. Miles got down to 30%, and also Alan Park's got it down to 30%, but it was really still quite high. And just be aware that local recurrence in rectal cancer is extremely unpleasant. These patients have tenesmus, they have pain, and they suffer a vast amount. So everybody understood it had to be improved. Now, you may wonder why I'm showing you a picture of Jane Austen. Well, the fact is that Jane Austen grew up just outside a place called Basingstoke, which is a town in just southwest of London, and is kind of the basis for where Pride and Prejudice took place. And it was in Basingstoke where in the 1980s a surgeon by the name of Bill Hield started reporting his outcomes, and he reported remarkably good outcomes. He said his 5-year recurrence rate was only 6%, which is far less than anybody else was reporting. And the reason was this, because Bill Hield had developed a new operation called a total mesorectal excision, and that involved the removal of the entire mesorectum as an intact unit. And here we can see that. So here you can see the rectum, there's the dentate line between the anus and the rectum, here's the tumor, and here's what it's called in this diagram, an incorrect dissection, here's a correct dissection. So what Bill Hill did, he took a knife and he very carefully dissected this plane to take out the entire mesorectum. What they did before Bill Hill came along is they did blunt dissection, which hard to believe, but I understand is basically the use of the hand, that you put the hand in, put it around the rectum, pull it out and cut it. But that left tumor cells behind, and so Bill's knife dissection was far better from an oncological point of view. Total mesorectal excision has become a worldwide standard of care, and be aware that the pathologist has an important role in TME, as they're called, in order to evaluate the quality, and the pathologist can see and he should see that there are no defects, that it's come out in entirety. And one of the things that they talk about is that the TME resection specimen should be a bit shiny. That shows that it's been removed in its entirety. So thanks to Bill Hield, he got the local recurrence rate down to 5 to 10%. Before we finish surgery, I just want to mention a few words about stoma. Stomas, I'm not a surgeon, but I think it's important, even for non-surgeons, to understand about stomas. First of all, the different types of stomas. You can have a colostomy, you can have which is connected to the large bowel. You have an ileostomy, which is a small bowel. Ileostomies are notable because they tend to be larger volumes which come out. And of course, I have a urostomy for urine. Now, even with a load of colostomies, you can have different types of colostomies, aside from left or right or transverse. But what's more important is you can do what's called a loop colostomy or an end colostomy. Now, many of the patients with rectal cancer, after they've had neoadjuvant therapy, will come out of surgery, in fact almost all of them will, with a colostomy. But that doesn't mean they've got a colostomy for life. What's normally done in these cases is the surgeons, they do a loop colostomy, where actually they've tied everything up at the bottom, but They want to keep the rectum, they want to keep it kind of sterile and clean to give time for these tissues to heal. And so they do a loop colostomy where they kind of pull it out to the skin, and so that the feces will come into the bag. And then a few months later, they'll close that up. They'll close up the loop colostomy. It's a very minor procedure, and then patients can go back to defecating in a normal manner. The second component of rectal cancer treatment is radiation, and that's what I do for a living. First of all, why do you need radiation? I mean, I would have thought if a tumor is removed in its entirety with clear margins, then kind of why does disease come back? And the answer is in this diagram. Here you've got an axial cut of a pelvis. In yellow you've got the mesorectal fascia, and that's where the TME is performed, the total mesorectal excision. The surgeon carefully removes all this area in yellow. However, there are other areas of lymph nodes, what's called the obturator or the lateral lymph nodes, here in red, and those aren't typically touched by the surgeons. In Japan they do tend to touch them, but at least in the West this is far the surgeons don't tend to operate in this area. So one of the reasons we need radiation is to sterilize this area over here. Just be aware that there's a relationship between the T stage and the N stage. So even small T2 tumors have 20% positive nodes, and when you get to T3 or T4 tumors, almost all of them have positive lymph nodes. So why do you give radiation in rectal cancer? Really, there are 3 or 4 possible reasons. As I mentioned, to avoid local recurrences, which are very, very unpleasant. In a certain percentage of cases where the surgeon thought he was going to have to do an abdominal perineal resection, giving irradiation first shrinks down the tumor and enables the surgeon to perform a lower anterior resection, sparing the sphincter. There's evidence that radiation improves overall survival, and in certain cases maybe patients won't undergo an ablation at all, and we'll talk about that a bit later. So without getting too far into the details of radiation therapy, this is the area we tend to radiate. You can see it's much of the pelvis, at least the posterior pelvis, including far more than just the mesorectal fascia. We tend to radiate from 3 directions, posteriorly and laterally, left and right. Just in one sentence, there are 2 traditions in how to radiate the rectum. There is the North American, Western Europe, Israeli way of doing things, which is to give radiation once a day, 5 days a week, for 5.5 weeks. And then there's the Northern Europe, Scandinavian method of doing things, which is to give radiation once a day, just for 1 week. Of note, using the American system, you give a touch of chemotherapy to give the radiation, capecitabine or 5-FU. In the short course radiation of 1 week, and from Scandinavia, no chemotherapy is used. So as I mentioned, radiation decreases local recurrence. This is from the Swedish study, and it showed that it doesn't matter. This is the old Duke staging. It's very similar to the AJCC staging of node very local disease, low negative and low positive. Wherever you are, whatever your baseline is, radiation decreases your risk of local recurrence by about 50%. In this Swedish study, it also improved overall survival. People then thought, well, if we're doing a TME, maybe you don't need radiation, so a large study was performed by the Dutch, and they gave everybody a TME. Half the patients got radiation. Also, in this population, once again, even though the absolute incidence of recurrence was much lower than in the Swedish study, nonetheless, once more, radiation decreased the risk of local recurrence by about 50%. So, to go back to North America and Western Europe. At this time in the 1990s, they were doing regular surgery, not TME, and they started giving radiation after a treatment, or rather they investigated it. And you can here say both in the British MRC trial and the North American NSPPP trial, the instance of local recurrence here decreased by 40 to 50% using post-operative radiation. So around the year of 2000, at least from a North American Western Europe perspective, it was known that post-operative radiation decreased the incidence of local recurrence by about 50%. But it's difficult to give treatments post-operatively. Patients aren't feeling well, they have wounds which are healing, and so the question was asked that maybe it's better to give radiation before the operation. So a large study was performed in Germany, which was subsequently published in the New England Journal, which compared pre-operative versus post-operative chemoradiation for rectal cancer. This is a very important study. It's one of the papers I've asked that you read. This is the most important results that came out of the study. This is the instance of local recurrence, and you can see compared to post-operative radiation, which is here, pre-operative radiation decreased the instance of local recurrence by 50%. So pre-operative radiation was more effective in preventing cancer recurrence than post-operative radiation. Now, there are always concerns, especially among surgeons, about irradiating patients prior to a surgery. Actually, here we see there were fewer side effects amongst those who had the preoperative radiation compared to postoperative radiation, 27 versus 40%, and also regarding long-term side effects as well. Moreover, surgical side effects were very similar and perhaps slightly lower amongst those getting the neoadjuvant radiation. So even though some surgeons are afraid of radiation, in my opinion, it's not really justified at all. Furthermore, very excitedly, they looked at patients who would require, it was estimated that they would require a abdominal perineal resection and a permanent stoma. Amongst those who underwent post-operative chemoradiation, so in the end, actually 81% of these patients did indeed have to undergo an abdominal perineal resection, an APR. However, amongst those who underwent preoperative chemoradiation, actually twice as many were able to preserve their anus. So neoadjuvant chemoradiation improves sphincter-sparing surgery, which is very important to patients. Just to go back in one slide to that debate between North America and Scandinavia, the short course versus the long course. So there have been a number of studies published in the last couple of years comparing these two regimens. The bottom line is that they seem to give very similar results. However, more patients getting the long-term American-style chemoradiation have a complete pathological response, and that treatment is more effective at shrinking down the size of the tumor. So in patients with low rectal cancers, we're concerned about having to undergo an abdominal perineal resection, lose their anus. We definitely tend to prefer long course radiation, and in fact it's still preferred in much of Western Europe, North America and Israel. So this kind of summarizes local recurrence where we are today. As I mentioned, surgery alone is about 30%, TMA is 5 to 10%, and with neoadjuvant chemotherapy, we've got the instance of local recurrence to be a very rare thing, about 2 to 5% of patients. Just one slide about chemotherapy. I understand you have got another lecture about colon cancer, and actually chemotherapy in colon cancer and rectal cancer is really identical. So I'll just mention that when we give long course radiation, we can combine it with capecitabine, also known as Xeloda, which is an tablet form of 5-fluorouracil. In terms of adjuvant treatment and metastatic treatment, it's really identical to colon cancer. So we mentioned the 3 components of colorectal cancer, of rectal cancer treatment: surgery, radiation, chemotherapy. How do we put it all together? So now this is an important slide. For patients who have very small tumors, and there are some very strict criteria for this. They have to be less than 3 centimeters, less than 30% of the circumference of the rectum, no perineal invasion. For these very small, very good tumors, it is acceptable to do local excision alone. However, if it doesn't meet those criteria, or if it's a T2 tumor, and then if it's T1 or T2, then the standard treatment is total prostatectomy, again, low anterior section or abdominal perineal section, depending on the location of the tumor. If you took patients to surgery and then when you get the pathology report back, it turns out you need to have a T3 or a node-positive tumor, then you do need to give them post-operative chemoradiation. If at the time of diagnosis you realize it's a T3 or a T4 or a node-positive tumor, then these patients require neoadjuvant chemoradiation. Or if you're in Scandinavia, you could, or anywhere for that matter, you give the Scandinavian style treatment of neoadjuvant short-course radiation. Subsequently undergo operation, and after operation they may require adjuvant chemotherapy. The precise indications for that are similar for colon cancer, although it's a little bit more controversial. And once again, for metastatic disease, the primary treatment is chemotherapy. However, many patients with metastatic rectal cancer do require treatment for their local tumors, either with radiation or with surgery or both, because the local tumors at some point or other tend to become highly symptomatic and have to be taken care of. So using the American style regimen, this is what treatment looks like. You give the chemoradiation for 5.5 weeks. You then have a 6 to 10 week interval as patients get over the treatment, and it gives time for the tumor to shrink down. They subsequently undergo their tumor resection, and then they may or may not require adjuvant chemotherapy afterwards. So in my final few slides, I want to talk about some new approaches. Some people are trying to avoid radiation, just give chemotherapy followed by surgery. That's being tested in the Prospect trial. Personally, I don't think it's a great idea, but we'll await the results of this study. I do want to talk a bit about total neoadjuvant therapy and watchful waiting. So, as I mentioned earlier, classical treatment is chemoradiation, surgery followed by more chemotherapy. In the TNT concept, which is being tested at the moment but has not been proven to be better, the chemotherapy is moved earlier on. So you give the chemoradiation, then you give the chemotherapy, and then you undergo a resection. I'll mention at this point that there are many variations to TNT. There's no precise definition. People often give the chemotherapy before the chemoradiation. Some people, instead of giving long-term chemoradiation, give short-term kind of Scandinavian short-course radiations. There are many combinations. Exactly how you do this is highly debated and unclear. But there's an increasing push to give TNT style treatment, especially in North America. Another new, interesting, and somewhat controversial topic is watchful waiting in rectal cancer. That is, patients who've had an excellent response to neoadjuvant chemoradiation, perhaps they don't require surgery at all. This has really been pioneered by colorectal surgery from Brazil, Dr. Habagama, I hope I pronounced her name correctly, and she really over the last 2 decades has really published her results and been pushing this approach. Recently it's gained traction in North America, especially at the Sloan Kettering Memorial Cancer Center, and they recently published their results in JAMA Oncology. Amongst a highly selective group of patients, they had pretty good results. They had about a 20-22% local recurrence rate. Now, as you're aware, if you've been listening to this lecture, actually that's worse than what we see with neoadjuvant chemoradiation. However, these patients, the vast majority of them, didn't have to undergo surgery and never acquired a stoma. So there are advantages with a watchful waiting strategy. However, it is only for patients who have undergone an excellent response to chemoradiation. Now, exactly how you define the word excellent is also unclear. So, a lot of factors that need to be clarified regarding the watchful wait strategy for rectal cancer, and still a matter of debate. Some ongoing issues. Very low rectal cancers tend to continue to be challenging because patients really want to try and avoid a permanent stoma. Elderly patients, as in any area of oncology, we continue to be challenged by elderly patients. What do you call elderly? 70, 80, 90? How do you define the word frail? And how aggressive should we be with these patients? But as patients live longer and longer, 70, for instance, seems like to be a fairly young patient. Quality of life. So another issue that we've tend to appreciated more over the last couple of years is asking patients how they feel, and this is a special relevance to patients' rectal function. So, for instance, even though you've managed to perform a low anterior resection and give patients a functional rectum and anus, it doesn't always function quite as well as we should like. So, for instance, there's a thing called low anterior syndrome, and this is patients who've undergone rectal cancer surgery, often with neoadjuvant chemoradiation, and even though at the end of the day everything is connected and tied up, they complain of urgency. They have to go many times to the bathroom to pass stool, and they have a poor quality of life. So just because it's been a surgical and oncological success, it doesn't always mean that you have a happy patient. And there are occasional patients who will request to have a stoma, not because of the cancer, but because they are suffering so much from low anterior syndrome. Worth mentioning as my penultimate slide that you can reduce your risk of colorectal cancer. This is a chart from the American Cancer Society. Have regular screening. Exactly how you screen, there are many different recommendations, but the way I recommend for my patients is from the age of 45 to undergo a complete full colonoscopy once every 10 years. But as you see in the literature, there are many variations of what to do. Sigmoidoscopies, occult blood testing, kind of many different opinions how to do it. Don't be overweight, physical exercise, and avoid those high-risk foods we discussed. Avoid processed meat, trying to avoid meat in general, and have lots of vegetables. And that's it. So thank you for listening. If you have any questions about rectal cancer or radiation oncology in general, you're welcome to be in contact with me. Thank you so much.